dear students, welcome back. In this session, we will take MCQs of anatomy. And for better visualization, please increase the resolution of your video, make it 1080 higher. So we can start the anatomy portion. And the very first question is about a clinical scenario of portal hypertension, in which we know that there is portal system anastomosis. So in lower end of esophagus, there is dilatation of veins. So which vein is the one which is actually draining into the portal vein? So for that, you need to know the concept of portosystemic anastomosis. Porto, or what you call portocaval anastomosis. And here, in certain areas of the body, a vein from the systemic circulation and a vein of the portal circulation anastomose with each other. And from exam point of view, you have to remember at least three areas. Number one is the lower end of esophagus. Number two is lower end of anal canal. Number three is umbilicus. Right. So these are the three areas where the common one where we have this portocaval anastomosis. And now the clinical significance is that whenever there is cirrhosis of liver which leads to portal hypertension, there is opening up of these portocaval anastomosis. So in cases of portal hypertension, which is secondary to cirrhosis of liver, there is opening up of these portocaval anastomosis. There is opening up of the Now, why you should know this? Because what happens whenever these portocaval anastomosis opens up, there are significant clinical findings. So suppose if there is opening up of the portocaval anastomosis of lower end of esophagus, patient will develop varices resulting in hematomas. Similarly, if there is opening up of the portocaval anastomosis of the lower end of anal canal, patient will develop hemorrhoids. And in cases of opening up of the portocaval anastomosis around the umbilicus, that results in hypertension. So this is a very beautifully correlated concept of portosystemic or portal anastomosis, and a student should remember at least these three. So there are veins which contribute to this portocaval anastomosis. One is from the systemic circulation and another is from the portal circulation. So in case of lower end of esophagus, the vein which is related to the portal system of venous drainage is the left gastric. So left gastric vein, as you can see, it goes and it drains into the portal vein. So this concept is very important from portal hypertension point of view about the portocaval anastomosis or portosystemic anastomosis. So one vein from the systemic circulation and another from the portal circulation, they anastomose each other, and whenever there is any pressure increase in the portal venous system, the condition is known as portal hypertension, and usually the value is more than 12 millimeter of mercury, then we call it portal hypertension, and this is seen in cases of cirrhosis of liver. So these anastomotic sites, they open up and they give varied clinical presentation. Right? So this is important from clinical point of view. Now again, very important question: if there is rupture of bulbar urethra, the urine can come out, and it can extravasate to some areas. Now for this you need to understand the anatomy of the urethra and the surrounding structures. So we know that in a male there are 4 parts, 4 areas of urethra, and the important one is, which is in relation to the prostate, is prostatic. Below that we have the membranous urethra, and then we have the bulbar, right, and then the penile part. Now the membranous urethra, if you look in the image, this red part is the deep perineal pouch, and the membranous urethra is actually passing through the deep perineal pouch. So if I draw like this, if this is the membranous urethra, then this is the deep perineal pouch. This is the deep perineal, and is membranous. Distal to that is the bulbar urethra. This is the bulbar. Now if there is any rupture to the urethra at this point, it can go either downward, it can go forward, or it can go upward, right? But it cannot go into the deep perineal pouch. So it will never go back into the deep perineal pouch. It can go into the superficial perineal pouch. So here this is superficial perineal pouch. It can go into the scrotum, or it can go into the anterior abdominal wall. So what you need to remember is that in cases of rupture of bulbar urethra, there is no leakage or extravasation of urine in the deep perineal pouch. So please remember this. So the urine can never go into the deep perineal pouch. Please remember this. Then moving forward to the next question, deep inguinal ring. Now for this you need to remember a little bit about the anatomy of the inguinal canal. So we have 2 rings. The inner one is the deep inguinal ring, and the outer one is the superficial, and in between the two we have the inguinal. This is now deep inguinal ring is a defect in the fascia transversalis. It is a defect in fascia transversalis, whereas the superficial inguinal ring is a defect in the external oblique aponeurosis. Please remember, it is defect in the aponeurosis and not in the muscle belly proper. This is defect in the external oblique. Yeah. So this is deep inguinal ring and superficial inguinal ring. So this is fascia transversalis or deep inguinal ring. We have some more questions lined up based on the same concept we will take later. Now there is a case with nerve injury of upper limb, and when we saw the thumb, it was laterally rotated and adducted. There was wasting of thenar eminence. Now if you add up all these points, yes, very good. Tape thumb, yes. So if you add up all these points, of course, this laterally rotated plus adducted thumb is what you call ape thumb deformity, and wasting of thenar eminence suggests that there is paralysis of median. So this is quite obvious. The answer is median nerve injury. So wasting of thenar eminence and ape thumb deformity is laterally rotated, and usually when we look at the thumb, if this is the plane of palm, the thumb is somewhat like this, but in cases of median nerve, it also comes to lie within the same plane as that of palm, and it is adducted because of overactivity of the adductor pollicis, which is supplied by ulnar nerve. Right. So this is a classical presentation for median nerve injury. Now, lateral boundary of Hesselbach's triangle. Now, Hesselbach triangle is very important in surgical discussions because it is the area for direct inguinal, and again we can take the little bit of anatomy of the inguinal canal. This is the deep inguinal ring, which is a defect in fascia transversalis, and this is the facial inguinal ring, which is a defect in external oblique aponeurosis. Thank you, Raghu. Thank you. So what happens now? Just the basic difference between the direct and the indirect type of inguinal hernia. If the herniated content is moving from the deep inguinal ring and traveling all the way through the inguinal canal and coming out through the superficial inguinal ring, this is indirect inguinal hernia. Right? So entry through the deep inguinal ring, traveling all the way through the inguinal canal and coming out through the superficial inguinal ring. But think of a condition where the herniated content enters through the posterior wall, comes into the inguinal canal and comes out through the superficial inguinal ring. So it is getting a direct entry into the inguinal canal, so we call it direct inguinal hernia. Clear? Indirect through DIR, deep inguinal ring, and direct through posterior wall. So this picture is clear. What is direct, what is indirect? Now, for direct inguinal hernia, there is a landmark, and that landmark is the Hesselbach's triangle. Therefore, it is very important for us to understand what actually is Hesselbach's triangle. If we on either side we have the rectus abdominis muscle, right? The back muscle either side, abdominis muscle, and here we have inferior epigastric vessels. These are the inferior epigastric vessels, both the arteries and the vein. So this area, whatever is this, all area is the Hesselbach's. That clear? So medially there is the abdominis, laterally inferior epigastric vessels, and below inguinal ligament. So this is how the boundaries of Hesselbach's triangles are defined, and therefore your answer will come out to be inferior epigastric. Yeah. So this is the lateral boundary of Hesselbach's triangle. And what is the importance of Hesselbach triangle? It is the site of direct, please remember, inguinal. So therefore it is so. So this is Hesselbach's triangle. Now, continuing the topic a little bit more, a male child presented with swelling in the inguinal area, and there was herniation of the intestinal loop along with spermatic cord reaching up to the scrotum. Now, the two types of inguinal hernia which we usually discuss, one is the direct, another is direct. Okay. So, the direct, as I told you, it is through Hesselbach's triangle, whereas indirect, it is through the deep inguinal. So, the entry point for direct is through the posterior wall of the inguinal canal, and for indirect it is through the deep inguinal ring. Now, clinically, direct is commonly seen in elderly people and indirect is commonly seen in. So, the moment you read the case history, if the condition is discussing some elderly person or a young male, then probably it is talking about direct. And if the case history starts with children, probably it is about indirect. Third, direct inguinal hernia is seen in persons who are doing, some activities which increases intra-abdominal pressure, like laborers, weightlifters, or persons with chronic cough or some other condition which increases intra-abdominal. Whereas indirect, it is developmental, as we know that the condition is seen in children, so it is developmental, right? So this is the basic summary of how we differentiate direct inguinal hernia with indirect inguinal hernia. Yes, of course, somebody rightly said the answer is indirect inguinal hernia, and Litters hernia is actually hernia of Meckel's diverticulum. Meckel's diverticulum. And femoral hernia, I think for that you need to understand the anatomy of femoral triangle, and especially the medial part, that is the femoral ring, which is occupied by the lymph node of Purkinje or Rosenmuller, and this is the area which is usually vacant. So there are some chances that the bowel may herniate, right? So femoral hernia occurs through the medial most compartment of the femoral canal. Right? So this is femoral hernia, and this is one of the most troublesome hernia because it is quite difficult to reduce, and the chances of strangulations are quite high. So it is kind of times it can be irreducible and it can lead to strangulation. Femoral hernia is quite problematic times because of that narrow point of entrance, narrow point of herniation of bowel, right, through the medial most compartment in femoral triangle. So anyway, so this is inguinal hernia. Now then we come to some movements of the temporomandibular joint. So again, you know that in temporomandibular joint, it is only the movement of the lower jaw or the mandible which is possible. The upper jaw maxilla is fixed. So we always discuss the movements of the temporomandibular joint in terms of movements of mandible. We always talk in terms of mandible. So whatever the position of the mandible is, we will say that movement is occurring at the temporomandibular joint. Now the word is retraction. Now what does the word retraction means? Suppose if I am taking the mandible forward, this is known as protraction, right? And if I am taking it back to the usual position, that is known. So protraction means forward protrusion, retraction means back to the position. Protraction and the opposite is retraction. Protraction means mandible pushed forward, and retraction means mandible taken backward to the normal position. Now this retraction is done by posterior fibers of temporalis. So the retraction is done by posterior fibers of temporalis. Protraction is done by lateral pterygoids, both medial and lateral. So protraction, which is also known as protrusion, means taking the mandible forward. So that is done by both the pterygoids, that is medial and lateral. And retraction is done by posterior fiber. So forward movement, backward movement. Forward by both the pterygoids and backward by the temporalis. Now, if we open the mouth, means the mandible is going downward. So that is known as depression. Depression means opening the mouth. Whatever movements we have to discuss, we have to discuss in terms of mandible only. So this is mainly helped by gravity. So this is mainly helped by gravity, easy to take it downward, and it is supported by lateral pterygoid. Clear? So depression or opening the mouth, that is by gravity and lateral pterygoid. And if we close the mouth, it means we have to elevate the mandible. Elevation or closing the mouth so here we have medial pterygoid, masseter, and closing the mouth or elevating medial pterygoid, masseter, temporalis. And then there is one more movement, and that is chewing movement. Chewing movements means side to side, like this. Chewing means side to side movement, and this is by alternate contraction of lateral pterygoid, medial pterygoid. So alternate lateral and medial pterygoids. Clear? So these are the different movements at the temporomandibular joint and the muscles which bring about those movements. So please remember, retraction, temporal. Clear? So this is about the movements of the temporomandibular. Now coming to inferior thyroid vein. Where is the drainage of inferior thyroid vein? So for there are three set of thyroid veins. So you draw thyroid gland something. Then this is internal jugular vein and this is brachiocephalic vein. So the superior and the middle goes into the anterior jugular vein, whereas the inferior thyroid vein goes directly into the brachiocephalic trunk. So it goes directly into the brachiocephalic trunk. So if you look here in this image, you can appreciate the superior going into the internal jugular vein, the middle going into the internal jugular vein, and the inferior going directly into the left brachiocephalic vein. Yeah. So this is the venous drainage of thyroid gland. Now, next question. All of the following structure passes through the substance of parotid gland except, now which of the following structure does not pass through the substance of the parotid gland? So here, one thing is, I think it should be very clear to all of you that the facial nerve, it travels through the substance of parotid gland and finally it divides into its 5 terminal branches. So facial nerve has to be remembered by everyone. Then the second structure which passes through the parotid gland is the retromandibular vein. And third structure related to parotid gland is the external carotid artery. So the answer here is internal carotid. If we take a transverse section, now this is the left side, right? So this is the left parotid gland. Help you to understand. This is left transverse section. And we are seeing from above, right? So you can clearly see that the facial nerve is traveling all the way. This is facial nerve, right? And it travels through the substance of the parotid gland and then it divides into its 5 terminal branches. Number 1. Number 2, you can see the retromandibular vein. So this is retromandibular vein. And third, you can see the external carotid artery. So 3 structures you can see in relation to the parotid gland. And of course, if you look little medially, you can see the internal carotid artery here, the internal carotid artery, which is nowhere related to the carotid. The answer has to be internal carotid artery. But please do remember 2 structures. One is actually obviously the facial nerve, which divides into 5 terminal branches, and retromandibular vein. Retro means, the word retro is behind. Mandibular, now this is the mandible, the mandible. The vein is behind. So this is parotid. Please remember facial nerve, retromandibular vein, and external carotid artery in relation to the substance. Now next question, a patient has road traffic accident and yes, Raghu, absolutely right. Patient has road traffic accident and then he had extradural hemorrhage and there is rupture of middle meningeal artery. So the landmark which is related to the middle meningeal artery is perion, and I think most of you must be knowing that perion is an H-shaped area, and this is one of the weaker areas of skull. And many times you must have seen that whenever someone wants to commit suicide by a pistol, they usually keep the pistol right on the perion. So, and also during surgeries, whenever we have to make the burr holes, we prefer this approach because it is quite easy for us to get into the inside of cranium, right? So pterion is one of the weaker areas, and this is related to the middle meningeal artery. So whenever there is a fracture of pterion, there are chances that there is injury to middle meningeal artery resulting in extradural hemorrhage, right? Now, the middle meningeal artery, it passes through which foramen? Can anyone answer? It passes through which foramen? Anyone? Passes through foramen. Now, the other, and obviously this condition is extradural, also known as epidural hemorrhage. That is one thing. We can just take the opportunity to discuss few words about subdural hemorrhage as well. Very good, Raninda, very good. So, subdural hemorrhage, what is the source? This is venous. So, epidural, extradural is arterial, subdural is venous, and there is tearing of the emissary, or what we call bridging veins, right? So, this is subdural, below the dura mater, and this is epidural, just above. And the source, epidural is arterial, subdural is, yes, very good, bridging veins. Now we can move on to the next question about trigeminal nerve. It supplies all the following muscle except. So which of the following muscle is not? Thyroid is supplied by cranial nerve. 7th, that is facial nerve. Anyway, no problem, please correct yourself. So your answer is right, but difference needs little correction. Thyroid, it is supplied by Malika. Yes, absolutely, you are. Styloid, it is supplied by facial nerve, right? Then lateral pterygoid, medial pterygoid, tensor valli palatini, all are supplied trigeminal. Next question. Now, old woman having a large abscess in the middle of the right posterior triangle, and for which incision drainage was done, but post-operatively she could not extend her right hand above her head to comb her. So it means she can't do something like this. So this movement was gone, especially after a surgical intervention in the posterior triangle of neck. Which structure might have been damaged? Any idea? Very good. The answer is exactly right. Sertraline, you are right. Raghu, you are also right. So there is a cut injury to the spinal accessory nerve, and there is, see, spinal accessory nerve supplies only two muscles. What are those two muscles? One is sternocleidomastoid. Of course, the second one, all of you have answered right, that is trapezius. What is the action of sternocleidomastoid? Any idea? Yes, Raghu, absolutely right. What is the action of sternocleidomastoid? It is turning the neck. You want to turn, sternocleidomastoid helps. And what is the action of trapezius? Shrugging of shoulder is one. Shrugging of shoulder is one, and second is, yes, Aninda, you are right. Sertraline, you are also right. Trapezius, one is of course shrugging movement, lifting the shoulders up, and second is overhead abduction of arm, or what you call it, shoulder joint, right? So beyond 90 degree, what do you say? Beyond 90 degree or up to 120. This is done by trapezius and supported by serratus anterior, right? So whenever there is a cut injury to spinal nerve, sternocleidomastoid movement will be gone, and also the action of the trapezius, that is shrugging of shoulder, as well as overhead abduction will also be gone, right? So in this particular case, the description is about the involvement of trapezius muscle as such. Yes, Aninda, you are right, more than 90, but up to 120, right? So please make sure that it is only up to 120 degree, because beyond 120 degree, there is a scapular rotation. There is no role of muscles as such. So I think we can take the shoulder abduction, a little bit of shoulder abduction also, because this is one very unique concept where different range of action, different muscles are involved. Usually this is not seen in any other joint, right? If I say 0 to 15 degree, any idea which muscle brings about 0 to 15 degree at? Yes, Raghu, absolutely fine, absolutely fine. 0 to 15 degrees, supraspinatus, then 15 to 90 degrees, deltoid, 90 to 120 degrees, trapezius, supported by serratus anterior, and 120 to 180 degree is scapular. Clear? So a unique concept, because otherwise at any other joint we never see this kind of differentiation in terms of the ranges of movement, right? So this is important. So this 90 to 120 degree shoulder abduction will be lost if there is injury to the spinal accessory nerve. Now, next question, this is very, and again repeated so many number of times. Again, you will see the push injury, and there is injury to the anatomical snuff box. Which bone might have fractured? I think everyone can answer this. Yes, Rubik, absolutely everyone is spot right. And here the anatomical snuff box, what are the boundaries of anatomical snuff box? Any idea? Medially, laterally. Aninda, you are absolutely right. Medially it is extensor pollicis longus, right? So this tendon is extensor pollicis longus. See here, the prominent tendon is extensor pollicis longus, and this is medially, right? So just make sure that you mark it right. This is medially, so this is extensor pollicis longus, and laterally you have the two tendons. One is extensor pollicis brevis and abductor pollicis. So these are the boundaries of anatomical snuff box. And why we teach so much about anatomical snuff box? Because whenever the patient has a push injury, fall on outstretched hand, there might be injury to the scaphoid. There might be the fracture of a scaphoid, and that presents as tenderness in the anatomical. So the clinical pearl is that if you see a case with push injury and complaining of pain at wrist, and if you can elicit tenderness in anatomical snuff box, X-ray might be normal, right? So don't get deceived. X-ray might be normal. Simply based on the fact that there is tenderness in the anatomical snuff box post push injury, it is a very clear-cut case of fracture, right? So if you find tenderness in the anatomical snuff box, you can simply say, yes, Sertraline, absolutely right. Ninda, you are also right. So fracture scaphoid. So this is a clinical diagnosis. What I mean to say, it's a clinical diagnosis. Very rarely in orthopedics, without X-ray, you make a diagnosis. So this is one of those fractures where even if X-ray is normal, just the clinical presentation is suggestive of fracture scaphoid. And X-ray might take around 10 to 14 days to show you the typical fracture line once there is bony resorption. Otherwise, this much presentation treated as a case of fracture scaphoid. And yes, certainly you absolutely right. We can give a cast in class holding position, and Aninda is also right. One of the complication is avascular necrosis. Complication can be right. So this is in short about scaphoid and its relation or its importance in terms of tenderness at anatomical snuff box. Let's move on to another question. Nerve supply of supinator is like which of the following? So here again, this is a two-step question. Firstly, you should know the nerve supply of supinator. Then you should know the nerve supply of all the four muscles given. Then only you can correlate that, okay, the nerve supply of supinator is same as that this particular muscle. Certainly, you are absolutely right. The nerve supply of supinator is radial nerve, and yes, certainly you are absolutely right. This is brachioradialis, which is also supplied by radial nerve. So these two muscles are having the same nerve supply. Now, what about the nerve supply of brachialis? Any idea what is the nerve supply of brachialis? Brachialis, then coracobrachialis and biceps brachii. Brachialis, coracobrachialis, and biceps brachii. All these three muscles are the muscles of the anterior compartment of arm, and all the three muscles are supplied by musculocutaneous. Very good, Dr. Arya. Right? So you can remember the mnemonic BBC, biceps brachialis, coracobrachialis. Remember? So anyway, this question is, I think everyone will remember it. Thanks everyone. Now coming to the nerve supply of deltoid, I think it's quite easy. All of you can answer. Very good, Raghu. So this is axillary nerve, and of course the other muscle which is supplied by axillary nerve is the teres minor. So these are the two muscles which are supplied by axillary nerve. Now, why I have kept this particular question? I just want to talk a little bit about the deltoid muscle as such. So deltoid muscle is, yes, right. So deltoid muscle is responsible for the rounded contour of, whatever the rounded contour of shoulder is visible, that is because of prominence of the deltoid muscle. Now, it is supplied by axillary nerve, and there are two ways of seeing the injury of axillary nerve. Anyone? What are the two ways in which axillary nerve can be injured? One is, we have already discussed while we were discussing, very good, anterior shoulder patient, and there is one fracture. Any idea what fracture? Yes, perfect, certainly in Raghu, very good. That is fracture of surgical neck. So these are two possibilities when there can be injury to the axillary nerve. This is post-traumatic. There is, yes, Aninda, it's fracture surgical neck, very good. Arya, perfect. There is one more possibility if you give the intramuscular injections of the deltoid wrongly, and if you directly poke the nerve, that is another possibility. But these are the two which commonly see in clinical practice. anterior shoulder dislocation and fracture neck of. Now coming to the clinical presentation of axillary nerve injury. As we know that it supplies deltoid, so the very first thing would be there would be loss of, very good, so there would, very good, there will be loss of rounded contour, and what we can see, we will see the bony prominences. We can see the lateral end of clavicle, acromion process. So bony prominences will be seen. Okay, so this can be correlated because that muscle cover is lost. Yes, Malika, absolutely right. I'll come to that. So there is loss of rounded contour, and that is makes the bony prominences are seen, and sometimes this is known as flat shoulder also. So this is one thing. Then of course, if the axillary nerve is gone, the deltoid is paralyzed, patient will not be able to do 15 to 90 degree of shoulder abduction. Clear? This we have already discussed. Like patient will say that I can lift up to 15 degree, but I will not be able to take it up to 90. And yes, if you passively take it up to 90, he will take it to 120 or even further. So that 15 to 90 degree range is gone. And third, yes, Malika, you are absolutely right. The axillary nerve, it gives sensory innervation to a small area on the lateral aspect of arm, right? The small area. So what will happen if the nerve is gone? You touch, patient will not feel anything. Right? So there will be anesthesia. There will be no sensations. And since that area is the place where the army people or the police people, they keep their regimental badge, so that particular sign has been known by the name regimental badge sign, right? So that is the reason why we call it regimental badge. Clear? So that is the reason why we call it regimental badge sign. So these are all manifesting axillary nerve LC, which are clinically detected as paralysis of deltoid nerve, and also the regimental badge sign. Okay? So please remember this much. Now we can move on to the next question. There is weak flexor pollicis longus and weak flexor digitorum profundus of the index finger. Which nerve could be involved? This is median nerve, right? Now I'll define it a little bit more. Now there is flexor pollicis longus, right? FPL. So pollicis means thumb. Any word, the moment you find pollicis, yes, thank you everyone. All of you are correct. Rinkesh, Rubik, Chiki, Aninda. Yeah, Aninda, you are absolutely right. So flexor pollicis longus, that pollicis means related to thumb. Now can anyone tell me the exact nerve supply of flexor pollicis longus? It is actually a branch of median nerve. So this is actually anterior interosseous. Clear? So this is actually anterior interosseous nerve, which is of course a branch of median nerve. And apart from this, there are two more muscles. One is pronator quadratus and third is flexor digitorum profundus. Now these three are the deep compartment muscles of forearm. Flexor aspect, right? So these three are the different deep compartment muscles of forearm, and all three are supplied by anterior interosseous nerve. The parent nerve is of course median nerve. So since we don't have AIN in the options, so we will go with the median nerve. That's perfect, right? So and in the rightly said, FDP has two parts, lateral part and the medial part. Lateral part is actually AIN and medial part is ulnar nerve, right? So lateral part will supply index finger and the middle finger, and medial part will supply the ring finger and the little finger. And therefore, the question is specifically mentioning the index finger only. So it means there is FPL and lateral half of, so this is actually lateral half, right? So the moment you have this kind of picture, you can say the answer is either AIN, and if AIN is not in the option, then you can mark. So please remember this much, don't mix up. Now, Sartorius muscle originates from anterior superior iliac spine. Very good, Sertraline, very good, Raghu. Anterior superior iliac spine. Yes. So in short, we write it as ASIS. Now, I just want to discuss few facts about Sartorius muscle. Yes, anyone can answer what is very unique about Sartorius muscle? Yes, anyone? It is the longest muscle in the body, right? One thing, it is the longest muscle. Taylor's muscle, very good. It is also known as the Taylor's muscle. And then origin, we already discussed in the question, the origin is anterior superior iliac spine. Then what about insertion? What about insertion? Yes, Aninda, absolutely right. What about insertion? Medial part of tibial condyle. So medial tibial condyle, somewhere nearer to the, somewhere medial to the tibial tuberosity. So what I mean to say, now ASIS is somewhere here, and if this is tibia, so the muscle, it goes something like this, and it is inserted something like this. So it has a, you can say, a curved course kind of thing. Right? So what happens now? Based on this, we can discuss the action of the muscle. Very good. Flexes both hip and knee. Very good. So action are at both hip joint and knee joint. What is the action at the hip joint? One is, of course, very said, well said by Sertraline. So flexion. Here also flexion. Then anything else? Here it will do abduction and external rotation. Clear? So flexion, abduction, external rotation. But at knee joint, it will do internal rotation. Please remember, at one joint it is doing external rotation, at another joint it is doing internal rotation. So this muscle actually helps us in sitting cross-legged on floor whenever you want to sit. So these are the movements which occur, and this is controlled by Sartorius muscle. So now, any idea about nerve supply? What is the nerve supply? Any idea? Nerve supply, anyone? Anyway, it is femoral. Okay. So please remember this much about that. Yes, yes, Sertraline, Saloni. Very good, very good. So please remember this much about Sartorius muscle, and yes, it is a muscle of the anterior compartment of thigh along with quadriceps femoris. Right? We'll move on to next question. While eliciting patellar tendon reflex, which tendon is stretched? So this is a kind of deep tendon reflex. So which tendon is stretched? Very good. So this is quadriceps femoris. This is quadriceps femoris. Sertraline, no problem, no problem. Please don't mix up in words. So don't mix up with quadratus femoris, right? Now, as the name suggests, quadriceps quadriceps femoris. Now the word quadri means 4. So the word quadri means 4. Here this is actually 4. Now can someone tell me what are the 4 muscles which are included in this muscle? Any idea? Yes, Aninda is right answer. What are the 4 components in quadriceps femoris muscle? It is quite easy. We have 3 vastus. Yes, there are 3 vastus. So yes, Sertolin, perfect. Iki, you are also right. So 3 vastus first, medialis, intermedius, and lateralis. Yes, these are the 3 type of vastus. So vastus medialis is one muscle, vastus intermedius is another muscle, and vastus lateralis is the third muscle. The 4th muscle is of course the rectus femoris. Here, so quadriceps femoris includes these 4. Number 1. Now, what is this quadratus femoris? Any idea what is quadratus femoris? Yes, Chiki, you are right. Rinkesh, you are also right. What is this quadratus femoris? This is a muscle in the hip joint. So this is a short external lateral stator of hip. Right? So please don't mix up quadratus with quadriceps. Yeah, number 1. Now number 2, we'll come to the question proper. So suppose is so this is the quadriceps muscle. Okay. Femoris. Then this is patella, and this is the real fibrosity, and this is the ligamentum. Is okay. So what we actually do, we stroke the ligamentum patelli, and because of that stretch reflex, there is contraction of the quadriceps femoris muscles, and there will be extension at the knee joint. So that is the normal knee jerk or knee reflex what we elicit, and this is a kind of deep tendon. Okay. So this is ligamentum patelli, which is a tendon of quadriceps femoris. I think this is a very basic question. Artery which is behind palpated behind medial malleolus. I think everyone can answer that. This is posterior tibial artery. Posterior tibial artery. Yes, posterior tibial artery. Now this is important. A needle has to be inserted by an intern, and it has to be inserted in the intercostal space. Now what is the preferred site? What is the preferred site? Very good, Rinkesh. The answer is upper border of the hip. Now, why, anyone can tell me why we prefer upper border of the rib and not the lower border of the rib? Any idea why we prefer upper border? For this, you need to know the anatomy of the rib. Now, in the lower part, there is one intercostal groove. So there is intercostal. Very good, Saloni. So there is intercostal groove. In lower part, and through this intercostal groove, the neurovascular bundle is passing. The neurovascular bundle is lying here. Neurovascular bundle, right? So the neurovascular bundle is some related to the rib in this manner. So suppose if someone is passing the needle this way through the lower end of the rib or the inferior surface of the rib, there are high chances of injury to the neurovascular bundle. High chances of injury to the neurovascular bundle. So therefore, never advise anyone go along the inferior border of the rib. Always and always go along the superior border of the rib like this, right? So upper or superior border of the rib, this is the safer area to introduce the needle into the pleural space, okay? Because of the arrangement of the neurovascular bundle in the lower part of the, yes, Saloni, absolutely right, neurovascular bundle, right? So upper part is always preferred. Now, which of the following does not pass through aortic opening? Any idea? Now, aortic opening is not a true opening. It is an osteopneurotic. Very good. Everyone is right. Answer is phrenic nerve, right? So, the aortic opening is not a true opening and it is just a osteopneurotic defect on the posterior part, and through this, the main structure which passes through this is the, of course, aorta, then thoracic duct and azygous vein. These are the three structures which passes through the aortic opening. And yes, someone, Aninda, you are right, the vertebral level is T12. So vertebral level, very good. Now, what is the importance of aorta passing through this osteopneurotic defect? Now, whenever we are discussing the openings in the diaphragm is a muscle actually, right? So it helps in respiration whenever it contracts, inhalation, relaxes, exhalation. So this opening makes sure that the point of passage of aorta remains unaffected with respect to the state of diaphragm. So if the diaphragm is contracting, no problem, or no change in the size of the lumen. The diaphragm is relaxing, there is no change in the size of the lumen, and this makes sure that the amount of blood which is going from the thorax to the abdomen to the lower limbs, it remains uninfluenced. That is a very beautiful concept of this aortic passage through an opening which has nothing to do with the state of, so it remains uninfluenced. Now, taking this concept for esophageal opening. Now, esophageal opening is through which part of diaphragm? Any idea? Level is T10, Malika, level is okay. Which part? Like, see, diaphragm is a muscle. So it has two components, muscular part and a tendinous part. In simpler terms, we can write it through the muscular part, right? It is through the muscular part. And why I am focusing on the muscular part? Yes, Malika, right? Why I am focusing on the muscular part? Because if you look at the anatomy, so the stomach contains and the esophagus doesn't have a mucosa which is well developed to tackle acid. So there is a mechanism by passing the LES through the muscular portion of diaphragm, because by the way of the tone of the diaphragm, this LES remains closed. So it acts as a pincher to keep the LES closed so that there is no gastroesophageal reflex. So this actually helps in preventing reflux. So I think this way you can understand that esophageal opening is through the muscular portion, because the tone of the muscular part of the diaphragm keeps the esophageal hiatus closed, and that prevents reflux of acid from stomach to clear. Yes, very good, Aninda, very good. So that will help you in understanding. And of course, the level is T10. Then apart from esophagus, there is left esophageal branch of left gastric arteries. They also pass through that. And the third one is the vena cava opening, which is through the central tendinous part, okay, through the central tendinous portion, which is at the level of thoracic vertebra, right? So this is in short, and through this there is passage of inferior vena cava, phrenic nerves. So this is in short about the diaphragmatic openings, and it is very important because diaphragm is a, yes, Rubik, you are absolutely right. Curve, Saloni, everyone is right. So this is very important because diaphragm is a partition between the thorax and the abdomen. And some structures have to go from thorax to abdomen, or some has to ascend from abdomen to thorax, so it should give passage. But the most beautiful concept is about the aortic opening, which remains uninfluenced with the state of activity. Anyway, next question. Which of the following does not drain into middle meatus? Yes. Answer, which of the following does not drain into middle meatus in the lateral wall of nose? Yes, superior meatus. Right. Now, yes, very good. Nasolacrimal, very good, Molika. So nasolacrimal duct, it opens into the inferior meatus. Now here you need to remember three things. First, number one is the supreme meatus. What opens in supreme meatus? This sphenoid sinus. And the second one which you should remember is the superior meatus. And what opens in superior meatus? This is posterior sigmoidal sinus. And the third one which you should remember is the inferior meatus. Very good, Aninda. Third one is the inferior meatus, and in inferior meatus there is opening of the nasolacrimal, right? So principally remember these three: supreme meatus, sphenoid sinus; superior meatus, posterior ethmoid sinus; and inferior meatus, nasolacrimal duct. Apart from these three, whatever else is remaining, it will open in the middle. So that way, rest all opens. That will simplify the way of remembering. So I think this way you can understand it and remember it. Now in middle meatus, we have two landmarks. One is the hiatus semilunaris. This is the hiatus semilunaris, and on the top of that we have the bulla ethmoidalis. This is bulla. And in bulla ethmoidalis, there is opening of the middle ethmoidal. This is bulla ethmoidalis. The raised area is bulla ethmoidalis, and below that we have the hiatus semilunaris, which has got opening for maxillary, antiethmoidal, and frontal. Please remember like this. So if someone asks you what is the location of bulla ethmoidalis, then you can clearly say that it is in relation to the middle meatus, and there is opening of middle ethmoidal. Very good, very good. Everyone is perfectly right. Bulla ethmoidalis in middle meatus, and that has the opening of middle ethmoidal. Please remember. I think this will summarize the lateral wall of nose and the openings of. You can see here, this is bulla ethmoidal. Below this, have the hiatus semilunar. Let's move ahead. A patient was operated on left submandibular gland, but accidentally his lingual nerve got damaged. So while operating on the submandibular gland, there is damage to the lingual nerve. Now, what will be the clinical effect of this damage? Now, yes, Molika, Saloni, yes, everyone is right. So there is loss of general sensations from the anterior two-thirds of the tongue on the same side. Yes. Now, anterior two-thirds, and on one side we can write taste sensations and another is general sense. These are the very good, Saloni. So anterior two-thirds taste sensations are carried by tympani, and general sensation is carried by lingual. Okay. Whereas from posterior one-third of tongue, both the functions are done by same nerve, glossopharyngeal nerve. Okay. So therefore, if there is any injury to the lingual nerve, it would lead to the loss of general sensation. Now, general sensation means cold, hot, touch. So these are all general sensations. And taste sensation, of course, sweet. This is how the differentiation has been done for anterior two-thirds and posterior one-third. And now we have discussed about the anterior two-thirds and posterior one-third. Now, how we demarcate, what is the point which, or what is that landmark which says that, okay, this is anterior two-thirds and this is posterior one-third. So what is the point of demarcation of the anterior two-thirds with posterior one-third? So this is circumvallate papillae. So suppose if this is tongue, and this is anterior third, this is posterior. So this is the demarcation of anterior two-thirds from posterior one-third. There is history of extraction of the third molar tooth, and after that, patient felt that there is loss of general sensation from the anterior two-thirds of tongue and floor of mouth. So which nerve might have? I think everyone can answer this now. So this is of course the lingual. Clear? So general sensations, anterior two-thirds, please remember lingual nerve. Yes. Very good. Now we know that palpate any artery, we have to press it against any base. So there has to be a bony resistance against with that artery pressed so as to feel the palpations. Now, if you want to feel the palpations of common carotid artery, yes, you're right, it should be pressed against the arch of cricoid cartilage. It should be pressed against the arch of cricoid cartilage. Like if you want to palpate the femoral artery, or if you want to palpate the radial artery, any idea? This is of course lower end of radius, and this is femoral. So the arteries, they have to be compressed against a bony background, then only we can palpate the pulsations. Now all are paired cartilages in the larynx except anyone? Now this is very basic. The answer is cricoid. So it is, you can see this is cricoid cartilage here, all cricoid cartilage, and is thyroid. Cricoid is the answer. Now this is important. Decussation of corticospinal tract. What is the point of decussation of corticospinal tract? Any idea? Yes, very good. This is lower medulla. Lower medulla. And if you look at the anatomy of the medulla, you can see prominences like these. These prominences are actually because of the corticospinal. Here, they're all tracts on corticospinal. And these prominences are known as pyramid. So therefore, many places you might hear the word pyramidal tract. Pyramidal tract is same as that of corticospinal tract, because pyramid is the area of the medulla which is occupied by corticospinal tract. And yes, below this point, the corticospinal tract crosses to the other side. Over. So lower medulla is the point of decussation of the corticospinal tracts. And corticospinal tract, as the name suggests, going from motor cortex and reaching up to the anterior horn cells, spinal. So this is the upper motor part, and from the spinal cord there is origin of the peripheral nerves which forms the lower motor neuron. Right? So this is corticospinal tract. Decussation at the lower. What is the correct sequence of brain structures going outside to inside? Now, to understand this, yes, anyone? Anyone? Here is the insular cortex. See the and medial to this there is putamen, is medial to putamen is globus, yes, and globus pallidus is like putamen plus globus pallidus is lenticular nucleus, right? So together these two are known as lenticular. And then we have the internal capsule here. Then this is all internal capsule here. Medial to internal capsule is the thalamus, and medial and superior to thalamus is the caudate. So, or you can just keep it should be superior and lateral. So we are going this way. Firstly, we will have the insular cortex. Then we have the lentiform nucleus, that is putamen and globus pallidus, and internal capsule. Then the caudate nuclei, and finally the thalamus. Thalamus is the most interior. This is A. So the answer becomes A. Yes, everyone is right. We like this. So if we look in the image, this is the insular cortex, the lateral temporal, and then we have the putamen, deep to putamen are the globus pallidus, externa and interna. Then we have the internal capsule. Then we have the caudate nuclei. This is always right. This is how, if we look in a coronal section. Okay, please remember. Now, not a feature of oculomotor nerve palsy. Now, before this, you should know the muscles which are supplied by the oculomotor nerve. So there is a mnemonic for that. SO4 R6 means the superior oblique supplied by cranial nerve fourth, lateral rectus cranial nerve sixth. Yes, everyone is correct. And all the remaining muscles, they are supplied by third, including levator palpebrae superioris. Now let us discuss the options. Levator palpebrae superioris, this is for elevation of upper eyelid. So if levator palpebrae superioris is gone, patient will not be able to do, there will be ptosis. So this is correct. Ptosis, this is because of paralysis of levator palpebrae superioris. Now, constriction of pupil is done by constrictor pupillae muscle, is supplied by third nerve. So if third nerve is gone, dilatation of pupil will be seen. This causes meiosis. And this is again light reflex, because what is light reflex? Light reflex, if you show light, there will be pupillary constriction. So afferent is cranial nerve second, and efferent is cranial nerve, right? So if third is gone, there will be loss of light. So what is left now? Medial and upward. So again, medial gaze is by medial rectus, upward gaze is by superior rectus, which are both paralyzed because they are supplied by third nerve. So medial rectus and superior rectus, these are paralyzed, so this will not be seen. This will not be possible in a case of palsy. Yes, Raghu, you are absolutely right. Dilated pupils will be seen, and outward deviated eyes because of overactivity of outward, and downward deviated because of superior oblique activity. So superior oblique muscle will depress the eye and will take the eyeball outward, supported by lateral rectus. Because in a particular structure, there is a balance between the agonist and the antagonist. If one muscle is paralyzed, the other group of muscles, they become overactive and they will try to pull the structure in their direction, right? So once there is paralysis of, you say, medial rectus, the lateral rectus will become overactive. It will pull the eyeball laterally. Once there is paralysis of superior rectus, inferior rectus, the superior oblique will become overactive and it will depress the eyeball. That is how Raghu said exact right words. Outward deviation of eye, and also you can add downward deviation of eye. That is the effect of. So this is all about paralysis of third cranial nerve. Now, next question: main branches of trigeminal nerve except. I think it is quite easy because we know that there are three branches of cranial nerve 5, cranial nerve 5-1, that is ophthalmic, cranial nerve 5-2, that is maxillary, and cranial nerve 5-3, that is mandibular. So yes, the answer would come out to be optic nerve, which is actually cranial nerve 2. Good. Now, next question: a patient has a swelling below the ear and he complained of pain in the lobule of ear, and then he cannot close his left eye completely and having difficulty in eating food. Which nerve is most likely damaged? Now here, firstly you have to understand there is a swelling below the ear, okay, and there is pain in the lobule of ear. So somewhat this is in discussion with the parotid gland, and one of the commonest tumor of parotid gland is pediatric adenoma, and we know that to the parotid gland we just discussed that there is passage of facial nerve. So, and this is one thing, facial nerve. Now secondly, if we discuss the features of facial nerve palsy, there is incomplete closure of the palpebral aperture. Palpebral aperture, because this is because of paralysis of orbiculus oculi, right? This is one thing. Then there is difficulty in swallowing. Then if you look at the face, there will be drooping of the angle of mouth, difficulty in puffing action. Okay. So these all go in favor of facial palsy, and that is related to the parotid gland. So whenever there is a tumor of the parotid gland, Yes, Monica, you are absolutely right. Unable to close eye, that goes more in favor of facial nerve. Absolutely right. So this is facial nerve. Now, continuing the concept, if there is a lower motor neuron lesion of the facial nerve on the right side, presentation would be seen. Element palsy, facial nerve, what presentation you will see? Yes, anyone? Yes, right side. Oh, absolutely well. Absolutely right. So, yes, Raghu, Sertalin, Malika, all of you are correct. So, there is right-sided loss of wrinkles over forehead and the right-sided corner of mouth goes down. So, this I already told you, that is drooping of the angle of the mouth on the affected side. So, what happens? This is lower motor neuron type of paralysis. And suppose if this is face, there will be affection of or paralysis of the same side. The same side will be paralyzed. So if we are discussing about right side, it means the right paralysis of half of the face. Okay. This is one thing. Number two, in relation to the angle of mouth. See, normally the angle of mouth should be something like this. But what happens whenever there is paralysis on this side, the opposite side muscles become overactive and they will pull the angle of mouth towards the normal side. So it goes up towards the normal side because of the normal muscles pull, and it is low on the affected. So this is what angle of, again this helps in diagnosing a lower motor neuron paralysis of facial. Again, you can see here in the image, the angle of the mouth tilted somewhat like this. The facial expressions are not possible. If you tell the patient to close the eyes, he will not be able to close the palpebral aperture completely. Yes, Malika, you are right. This is Bell's palsy. This is lower motor neuron type of paralysis. Now, what actually is this lower motor neuron paralysis? Is this like we have, so this is the motor cortex. Where is the nucleus of facial nerve? Facial nerve nuclei in mid pons. Pons. And the fibers which are coming from motor cortex to the facial nerve nuclei, these are all upper motor neuron. And these are also known as the corticonuclear corticobulbar tracts. And the facial nerve will emerge from here, and this all constitutes the lower motor into the. So this is the concept of lower motor neuron. If the nerve proper is injured, that is, yes, Raghu, absolutely right, 5, 6, 7 neurons. So if the nerve proper is injured, that is lower motor neuron. If there is an involvement of the corticomotor tracts, that is upper motor. Right? So I'm just discussing lower motor neuron. This we have already discussed, inability to shrug and elevate the shoulder. Which nerve? Again, this is a function of trapezius, and we know that the nerve supply of trapezius is spinal SSA nerve. So, the point we have already discussed. Raghu, you are absolutely right. Yes, Hari, you are perfect. Now, which joint is involved in looking right or left? Any idea? Or In other words, movement of no. You want to say no. This is yes, right. Is pivot joint, and which joint actually is this? This is so. Right? It's a pivot kind of joint and movement of no. So I think we can take short break. You the side of